Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal, Pegadas Institute of Medical Sciences. Today I am going to discuss with you the difference between partial pressure of oxygen or PaO2 and peripheral saturation of oxygen or SpO2. This is a comparatively a bit confusing topic. PaO2 is determined by ABG and peripheral saturation of oxygen or SpO2 by pulse oximetry. So let us see what is PaO2. PaO2 is the tension of oxygen, or it is actual oxygen content in the arterial blood. So when it is in arterial, it is called PaO2. So it is a partial pressure of oxygen in the arteries, that is the PaO2. You are aware that the oxygen molecules are dissolved in plasma and also carried by hemoglobin. It is the oxygen molecule that is dissolved in plasma that is being measured in the PaO2. Oxygen molecule attached to hemoglobin is not measured in PaO2. Hope this point is clear to you. And PaO2 cannot tell you how much oxygen is present in the blood. For identifying the amount of oxygen present in the blood that is carried through the hemoglobin and also dissolved in the plasma, you should know the SpO2 and amount of hemoglobin also. Let us see what is oxygen saturation, commonly called as SpO2. In the picture we can see the hemoglobin molecule is represented. The red one is the oxyhemoglobin and the blue one is the deoxyhemoglobin. Hemoglobin molecule, the heme of the hemoglobin has ferrous ion and to this oxygen binds. There are 4 heme sites and so each hemoglobin molecule can carry 4 oxygen. When the sites are occupied by oxygen molecule, the hemoglobin is called oxyhemoglobin and it is saturated with oxygen. That is, the oxygen binding sites are occupied by oxygen. The hemoglobin is a saturated one or saturated with the oxygen. So basically SpO2 is looking at the percentage of all the available heme binding sites which are saturated with oxygen. Hope that point is clear. So SpO2 is actually the percentage of oxygen binding sites which are saturated with oxygen. It is important to remember that the SpO2 will not reveal how much oxygen is in the blood. As mentioned earlier, we should know what is the hemoglobin content also. So oxygen content in the blood, sometimes called CaO2, can be calculated by a simple formula. Hemoglobin in grams per deciliter into 1.34 ml, because each gram of hemoglobin can carry 1.34 ml of oxygen, multiplied by saturation of oxygen, to which you have to add the amount of oxygen that is present in the blood. That is calculated by PaO2 into 0.003. So this is how you calculate the total amount of oxygen that is carried through the blood. The oxygen hemoglobin dissociation curve shows the difference between SpO2 and PaO2. On the x-axis it is a PaO2 and in the y-axis it is the percentage saturation of oxygen or SpO2. The oxygen hemoglobin dissociation curve shows the percentage of oxygen binding to hemoglobin. That is, here it is written as a percentage. And oxygen saturation or SpO2 90 can occur with a PaO2 of 60. And cyanosis occurs when the SpO2 is less than 85. So you can see that the partial pressure of oxygen significantly drops, or even when it significantly drops, the SpO2 will be showing a high value. That is, even at 60 millimeters of partial pressure of oxygen, saturation is 90%. This is an important point to be kept in mind. So this picture clearly shows the SpO2-PaO2 relationship. At 40 PaO2, SpO2 will be 70. You can see 40 it is around 70. At 50 it is 80, and at 60 it is 90. So basically you can calculate this by subtracting 30 from SpO2 value gives your PaO2. So if your SpO2 is 90, the partial pressure of oxygen is 90 minus 30, that is 60. Hope this point is clear to you, and it should be kept in mind while interpreting SpO2. So let us see what are the normal values. 80 to 100 per PaO2 is an acceptable PaO2. So it varies between 80 to 100, but it depends upon the age of the patient. 60 to 79 is mild hypoxemia, which is tolerable. 40 to 79 is considered moderate, and less than 40 is severe hypoxemia. So usually our target is to maintain SpO2 is 90 and partial pressure of oxygen around 60. In a patient with COPD, supplementation of oxygen is indicated when the PaO2 becomes less than 60. So our policy is to maintain SpO2 at around 90. SpO2 is determined by the pulse oximetry around 90. And in patients with exacerbation of COPD, our target is 88 to 92%. So oxygen is supplemented in such a way that SpO2 is above 88 and the target level is 92. We look into the oxygen dissociation curve a bit more detail. As the partial pressure of oxygen rises, that is the PaO2 rises, affinity for oxygen molecule to hemoglobin increases. The more oxygen is bound, it is easier for the next oxygen molecule to bind. So the speed of binding increases and the oxygen saturation percentage rises rapidly. So here you can see that as the PaO2 is increases, the curve rapidly rises. And at around 60, it reaches 90. When all the hemoglobin, the oxygen sites are completely bound, it is 100% saturation. This particular feature of the hemoglobin or hemoglobin dissociation curve helps to rapidly pick up oxygen when the blood is passing through the lungs. As PaO2 falls, that is the partial pressure of oxygen falls, the reverse happens rapidly, the SpO2 falls. So at 90, PaO2 is 60, and then you can see that there is a sudden drop. As the PaO2 comes down, hemoglobin binding sites become less attracted to oxygen and fewer molecules are attached or more molecules are released to the tissues. Now the question is, the SpO2 of 90, is it okay or is it normal? Normal PaO2 is between 90 to 100. The partial pressure of oxygen by ABG is 90 to 100 somewhere around 80 to 100 is okay. But a partial SpO2 of 90 considering as normal is totally wrong. Just been explained already. As SpO2 of 90 is equal to partial pressure of 60, that is when the SpO2 is 90, the partial pressure is around 60 only. So there is a significant hypoxemia is there. And remember, this is the minimum oxygen concentration required to give oxygen to tissues to prevent ischemia. That is SpO2 of 90 or a partial pressure of oxygen of 60 is the minimum one which is required to prevent ischemia. Once the oxygen saturation falls below 90, that is SpO2 becomes less than 90, the partial pressure of oxygen is dropping rapidly and tissue can develop ischemia. Now the next question is, an oxygen saturation of 100%, is it normal? A very simple formula to estimate the arterial oxygen concentration or PaO2 is multiply the inspired air with 5. So atmospheric air contains approximately 21% oxygen and the PaO2 is around 100, 21 into 5. Let us see the example of a patient breathing 50% of air, oxygen, FiO2 fractional oxygen concentration 50% and PaO2 is 100. As mentioned, someone breathing room air at 21% oxygen should have a PaO2 around 100. So the patient is breathing FiO2 50%, the PaO2 should be 50 into 5, that is 250. A PaO2 of 100 and PaO2 of 250 both give oxygen saturation 100%. Because once SpO2 is 100, that is all the sites the oxygen is bound, whether the SpO2, the partial pressure of oxygen is 100, 250 or above that, will not increase the SpO2. That is, once all these sites are saturated, whatever it be, the PaO2, further SpO2 rise cannot occur. So SpO2 should be interpreted cautiously, and hyperoxia, that is increased oxygen, which can be dangerous, is to be avoided, and that is why the target usually we keep it around 95, or COPD patients target is around 92. Hope this is clear to you. The factors interfering with accuracy has been already mentioned. This includes pigmentation, nail polish, non-pulsatile blood flow, abnormal hemoglobin, movement, and many times a very low partial pressure of oxygen. The importance of hyperoxia and how it affects the SpO2 is already mentioned. Even though there are so many pitfalls are there, oxygen saturation has become a standard of care and is considered as the 5th vital sign. And remember, pulse oximetry is a better measurement of oxygen delivery to the tissues. That is, it is the availability of oxygen at periphery is better identified by the pulse oximetry than by the PaO2. PaO2 is the oxygen tension in the arterial blood and is best way to determine how well the lungs are working. So PaO2 will not clearly identify what is the oxygen given at the periphery. And SpO2 is a better measurement of the systemic oxygen delivery to the tissues. And it is a dynamic one also. An ABG leads on to another ABG, because in ABG once taken it will have some abnormality and will you again repeat. But here it is a non-invasive method and it is a dynamic one. So oxygen saturation has got several advantages over ABG analysis of the PaO and PaO2. And again, PaO2 values are often misinterpreted. PaO2 values are always much lower than oxygen saturation value. That is a point to be kept in mind. That is, PaO2 values are much lower than that of the SpO2. A saturation of 88%, which is seen in many COPD patients, the PaO2 is around 55. And SpO2 of 88%, you are very comfortable. But when you hear that it is 55 PaO2, you become uncomfortable and will be concerned. And this case, sorts of mild hypoxemia, the PaO2 will be surprisingly low and can lead to unnecessary increase in FiO2 and PEEP and delay extubation. That is a point to be kept in mind. So our target is around 90 to 94, and in a patient with COPD, you should have the target at 92. Don't increase the SpO2 more than that, and rely on the SpO2 rather than the PaO2. And when PaO2 or partial pressure of oxygen is relevant, first and foremost, when the SpO2 values are indeterminate. Second is when the photoplethysmograph, that is the waveforms which are seen, is not clearly visible. When you are suspecting abnormal hemoglobin like methemoglobin, again you may have to go for the PaO2, and methemoglobinemia can lead on to refractory hypoxemia, which has been discussed while we were discussing about cyanosis. PaO2 is important in the calculation of PaO2 FiO2 ratio in specific therapeutic conditions and decisions when a patient is intubated, as in case of ARDS, where the decision to proning is taken on this ratio. And so ABG analysis and interpretation of PaO2 becomes relevant. In summary, we have discussed what is PaO2 and what is the difference between PaO2 and SpO2, and the oxygen dissociation curve and the relevance in interpreting SpO2 and PaO2. We have discussed the pitfalls of SpO2 and what are the situations we will be looking at ABG. In summary, we can say that when the pulse oximeter, as shown in this picture, shows adequate waveforms, that is this value, this is the waveforms that is seen, and this is the SpO2 value written as 97, meaning 97% of the oxygen binding sites are saturated. And if the waveforms are clearly seen, pulse oximetry may be better than PaO2 in assessing the oxygenation. Hope the topic is clear to you. If you like this, subscribe the channel and share it and give your comments. Thank you. The next session will be discussing in detail regarding pulse oximetry.